Today I am presenting a case of hearing loss in joint. My patient, 35 years Hindu male, clad by occupation, resident of Bavla. He came to us with the chief complaint of abdominal discomfort, 20 days, fever 14 days, slurring of speech, impaired hearing, dizziness, difficulty in walking for last 4 days. So, elaborating my chief complaints, patient was apparently asymptomatic 20 days back. Then he had complained of upper abdominal discomfort, more after intake of food, with loss of appetite and early satiety. There is no history of nausea, vomiting, diarrhea, weight loss or bleeding from any side. 7 days later, he developed fever. 100 to 101 degree Fahrenheit, continuous, not associated with chills and rigor, but had headache and body ache. Fever subsided by the antibiotics for the time being. No history of coughing, running nose, rash, pruritic spot, joint pain or dysuria. On the 10th day of fever, he had sudden onset slurring of the speech without any deviation of angle of mouth, blurring of vision or any convulsion or LOC or difficulty in dictating. Along with that, he had diminished hearing on both sides of the and can listen only to loud voice without any earache or any discharge. He also has dizziness, imbalance during walking, and he needs supports. Coming to his past history, he had an abdominal pain 3 months back, treated by a local physician, and at that time they have undergone invasive procedure upper GI endoscopy, which shows patchy duodenitis. And also at that time they detected that he had diabetes mellitus type 2 and hypothyroidism. He had no other history of TB or contact with tuberculosis, and though there is no history of similar illness in the past. Coming to personal history, he is a alcoholic, chronic alcoholic since 10 years, non-smoker, mixed dietary habits, married from last 8 years, 1 son, no history of sexual promiscuity, blood transfusion or intravenous drug abuse. There is no bladder and bowel disturbance. Family history is non-significant and there is no history of epilepsy in the family member. All family members are in good health. Treatment history from last 3 months, he is taking metformin, levothyroxine and omeprazole. So now we do the general survey of the patient, and at the time of admission he was drowsy and slow response to the verbal commands. He is averagely built, averagely nourished, moderate degree of pallor, but there is no evidence of icterus, clubbing, cyanosis, edema, lymphadenopathy, skin rash. Jugular venous pulses are not raised, higher and not palpable. His pulse is 98 per minute, regular, normal in volume, no radiolateral, no radiofemoral delay. BP 110 by 70 electromercury right arm supine position. Temperature 101 degree Fahrenheit, height 5 feet 7 inches, weight 68 kg, BMI 26.8. So by this we go systemically one by one, and first is the central nervous system examination. Higher mental functions, he is drowsy, and so there is poor cognitive function, mild amnesia for the recent events, and there is no hallucination or delusion. In the cranial nerves, all the cranial nerves are okay, fundus is normal, except the vestibulocochlear, the 8th nerve, with rhinitis positive bilaterally and vivatus central. Yes, sir.
But is there no problem?
No, sir.
No visual problem?
No, sir. He have rhinitis positive bilaterally, vivatus, and clinically he have decreased hearing. Other are normal. In the motor part, the nutrition is normal, the tone is decreased, hypotonia is there, power all limbed 4 by 5. All deep tender reflexes are present, along with pendular knee jerks bilateral. Superficial reflexes are present normally, and plantar or bilateral flexure. In the coordination, there is a cerebral dysfunction in the form of dysphagia present, finger nose test positive, hearing test positive, misdiagnosis there. There is ataxia with broad-based gait, and involuntary movements are in form of intentional tremor. No other abnormal movements are seen. Sensory system and the meningeal sensory system is within normal limit and there is no meningeal irritation. Coming to the next is the gastrointestinal system. On inspection, the oral cavity is normal, abdomen fullness seen, no venous prominence, umbilicus centrally placed inverted, no ulcer, scar, sinus or pigmentation. Veins are not full. Hernial sites are normal, no visual pulsation, peristalsis, localized swelling. On palpation, the surface temperature is mild raised, but there is no guarding rigidity, tenderness, and the abdominal girth is 84 cm. Liver is palpable, 2.5 cm below right subcostal margin, the midlateral line. Non-tender, firm, margin is regular, rounded. Surface is smooth with normal consistency. Spleen just palpable below left subcostal margin. Lump, not palpable, no lump. Testes are normal. On percussion, there is no shifting dullness, and the liver dullness is present in the fifth intercostal space. On auscultation, intestinal peristaltic sounds are present, and on rectal examination, it's normal. The respiratory system, on inspection, the chest is normal, and on auscultation, bilaterally vesicular breath sounds is present, and there is no abnormal breath sounds in form of bronchocavitation. In the cardiovascular system, both heart sounds S1 S2 normal, and there is no murmur audible. So to summarize my case, a 35-year male, known diabetic and hypertensive for last 3 months, presented with upper abdominal discomfort, 20 days, fever for 14 days, slurring of speech, bilateral diminished hearing, dizziness and imbalance during walking for 4 days, with generalized weakness. There is moderate degree of pallor, temperature is 101 degree Fahrenheit, hepatosplenomegaly, impaired cognitive functions, amnesia, mild degree, with 8 pain no involvement in the form of sensory, in the loss, hearing loss, and cerebellar involvement is there with intact pyramidal tract.
Thank you. So this is another very interesting case stimulating our cerebral cortex. So the picture started with abdominal pain, fever, then went upwards. There is decrease in the cognitive function with 8 nerve involvement and cerebral involvement in a background of a patient who is alcoholic, have diabetics and hypothyroid. So can we put into one box? So anybody? অভিজিৎ বলবে কিছু? অভিজিৎ?
Now, one important thing is that this patient was febrile. Febrile with altered sensorium and these neurological findings, and there is also pallor and hepatosplenomegaly. So we should think about, as there is pallor and hepatosplenomegaly, we have to think about the infectious causes first, like malaria, the cerebral malaria, with involvement of these parts of the brain, giving rise to these features. And we must also keep in mind the other infections, like viral infections, like viral meningitis or viral encephalitis, like that. So I think we should start in this way.
So your
and then
first year
infections.
Shivandu?
I think it's very difficult to put everything in a single box. Patient is alcoholic, diabetes, fever, hepatosplenomegaly, and some features of cerebral. Is it cerebral or something memory body's dysfunction? Can it be the patient was treated with drugstores in your okay?
He has hearing loss. The main panic key is the hearing loss. He is a young patient and suddenly he has the hearing loss. Along with that, we have the 4 days of this imbalance during walking and dizziness.
Is that real amnesia? Is it a retrograde? Is there any features of signing of warning Korsakoff type of this thing? And that was advanced after being treated in your institute. Is there any such history?
No, sir. He came first time to our institute.
2 weeks fever followed by hours.
Before fever, pain after.
Pain
But
and
I was treated somewhere some abdominal discomfort and
Is the patient was getting alcohol daily almost? Is it alcoholic
Yes,
or?
sir, he takes daily, never daily.
So I think this problem should be considered in that way rather than putting in the single box. We have to think of so many things. The hepatic disorder patient has got features of warnings, patient has got any features of cerebellar disorder, cerebellar infection that produces the CNS involvement, retina palsy and with cerebellar disorder and hepatosplenomegaly. I think these three considerations should be taken all the time. It is very difficult to put everything in a single box. Difficult.
Sir,
I think I was fully agreeing the comments by Dr. Pal, Dr. Ghosh. But only one thing I was thinking, if you look at the caption shows or says that it is predominantly hearing loss. So as soon as you come across a patient of hearing loss, several things come into his mind in a clinical setting. Because the patient has got some endocrine problem, I see that he has got diabetes, he has got hypothyroid, etc. And we are well appreciated that there is a condition known as MELAS, mitochondrial encephalopathy with lactic acidosis, and stroke-like, not stroke, but stroke-like. But everything is not, can be put into one box in that MELAS. Number one. Number two, the patient, everything started with pain abdomen as our chairperson was referring to. Patient is alcoholic, there is some findings in terms of hepatosplenomegaly. So I think whether there is an abdominal problem, beginning like alcoholic pancreatitis or any other related problem, and that has spread to the systemic causes, including that. I was thinking of, obviously I was thinking on, as Vijay was telling, not for some, I was thinking of Bernese encephalopathy, which is often a very treatable condition, but if you cannot stamp the diagnosis, but the presentation is somewhat different. Predominantly there will be some cerebellar, maybe there some lower cranial nerve involvement, third, fourth, etc.
there is the external optional.
Yes, there is some cranial involvement. So I was also looking at that point. And thirdly, of course, obviously, patient had fever. So rationality is that we have to think of some febrile condition, some infectious cause, whether he has got any infectious in the form of viral. I think mostly viral he have got. But malaria also one should think of in this setting because the patient pallor, hepatosplenomegaly, etc. But the predominantly cerebral involvement in malaria is rather very unusual. I think that way I just put forward two probable associations in the form of MELAS, mitochondrial disorders, or in the form of Vernix and alcohol-related problem like Vernix. Thank you.
Well, let us proceed.